I will call the Human Services Committee Board meeting to order. This agenda was posted in the office of the county clerk on the 22nd day of July, 2020. Notice was sent to the West Bend Daily News, Express News, WIBD, WMBZ Radio, WTKM Radio, My Community Now, Hartford Times Press, Kewaskum Statesman, and the Milwaukee Journal Sentinel. And we do have everyone here this afternoon. So would you please rise for the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, the next item on our agenda is the consent agenda. I would entertain a motion to approve.
I'll move.
Is there a second? Peter? Okay. All those in favor, please signify by saying aye. Aye. Opposed, and that motion carries. And then the only other item on the agenda today is a discussion item on the future of Samaritan. Mary Beth, I understand you're going to start us off. Okay, the floor is yours.
So we'll see if I can multitask and hold this down and plug ahead with the PowerPoint. So thanks for letting me be a part of this program. I appreciate that greatly. I get a chance to talk about the history of Samaritan. I can tell you I haven't been there since the beginning. My hair might indicate that, but I haven't been there. But I wanted to start just with a quote from Thomas Jefferson, who said, I like the dreams of the future better than the history of the past. But I think the history oftentimes kind of sets the stage for us. So I'm very quickly going to do that for us today. Whoa. So the beginnings of Samaritan really go back over 100 years, providing long-term care services to the community as a whole. It was initially known as the asylum or the poor farm, which was pretty typical for a lot of counties at the time. Mental health issues were certainly something that were not the same in the identification or treatment of. And so oftentimes some of those issues were maybe misdiagnosed, what we would say at this point, and folks were housed in what was the Samaritan or the poor farm at the time. There also was the work farm, which for many people that didn't have funds, they might be moving to that to this location, the annex at that time, and providing either help on the farm and with produce or milking or that sort of thing. And so that was kind of a neat, sustainable piece at the time. So in 1968, you can see the annex in the background. That was the original building. Then in 1966, the county broke ground for this new building. It was going to again be kind of a state of the art piece and active the active treatment for the mentally ill, as well as adults that needed housing. So the layout of the building at that time is what we have now. It's a large 5-story, over 140,000 square foot building. Those of you that have been in it certainly understand that we have a pretty solid construction for the building itself. It was really built with a medical model in mind, which was typical of nursing homes at the time. So there are what we call double loaded corridors, where we have rooms on both sides, many double rooms at the time. There were centrally enclosed nurses stations that had glass all the way around. The cement block walls, tile floors, minimal office space, and really the needs of the residents at that time were significantly different than they are now. At that point, too, it was solely identified as a nursing home. You will sometimes hear the terms SNF, that would be a skilled nursing facility, which is what we are now, taking Medicare payments, more of the insurance end of it. At that time, from it being built, it was solely a nursing home, so there was the acuity level was not nearly as high as what it is today. And then providing long-term residence care. And in the picture, as we were going through, we found a picture of President Reagan making a visit to the county. So I thought that was kind of worthwhile putting in. At the time, initially, there were 332 beds that were built at the Samaritan. In 2009, it was decided that there would be some major remodeling that would be done for the building itself. Predominantly, it was trying to meet market needs and the needs of the individuals across our county, both residents and families. So the beds were reduced from 332 down to 131. At that point, we became Medicare certified, so the therapy needs increased pretty dramatically. The construction included 119 private rooms. At that time, early in the 2000s, that was pretty advanced and certainly recognized the needs of individuals as far as privacy and dignity. So we do currently still have 6 semi-private rooms and then 4 bariatric suites that we have specialized equipment. All of them have their own private bathroom, and that too is pretty significant for dignity needs. At that time on the first floor, so you come in on ground floor, or you're coming on second floor, excuse me, then there's first floor below, and then there's also a ground floor. First floor was converted to a community-based residential facility, and you'll see the initials CBRF. That's a different licensure, and I'll talk about that in just a minute. Talking about the why, that's something that I think we focus on a great deal here. Really the why of why that construction was done at the time was to address the consumer needs and operationally take an old building and try to make it better from an operational standpoint for both staff and the residents. Regulatory changes continue to happen as well as the market needs and individuals looking for specific levels for living. So currently our primary populations have changed quite a bit from especially from the initial 60s. We have a strong growth in our short-term rehab population. We are housing that population predominantly on our second floor. That's also the floor where anybody that's coming from the hospital or that has been re-hospitalized, we're doing a 14-day quarantine on that floor so that we can work well from an infection prevention standpoint. Short-term rehab, predominantly folks are there less than 30 days. So there are some joint, hip, knee replacements. We're not seeing a lot of those, a lot of wound care, a lot of IVs. We're running multiple clinical needs with individuals right now. Our third floor has predominantly dementia and cognitive abilities challenges that residents have that still need skilled care, but predominantly we try to keep those folks in one area. Staff, we talk a lot about non-anxious presence so that we have some specialized programming for that population. And our fourth floor really are our long-term care, very highly clinically complex. So they're needing a nurse around the clock and to deal with the needs there. Throughout the building, based on what comes forward for us, we continue to be the Chapter 55 location for the county. So that is something that the state requires each county to have a location for Chapter 55 individuals. And those are individuals that need to be protectively placed for some reason, whether they're having some of their own individual issues and don't have a placement that is appropriate for them, or might be in a possible abuse situation, And we get those pretty routinely. We're averaging about 10 a year. It ranges, upwards about 13. Right before I left today, we had another referral. So we certainly try to be very accessible to the county as a whole. As I mentioned, we have an assisted living, or CBRF, community-based residential facility on our first floor. We have 31 units, and that was converted in 2009. And then additionally in 2006, kind of in between there, a residential care apartment complex, or RCAC, was built, lovingly known as the Fields. And there we have 24 units, individuals that either have a one-bedroom or a studio apartment. Those individuals tend to be a little bit more independent. That licensure allows for aging in place. So an individual can have up to 28 hours of care in that situation. In our CBRF, it's licensed a little differently, and we can have up to 3 hours of professional nursing care in that situation. Yes, per week, yes, yeah. The Whiffley report is going to address this in a little bit more detail, but one of the things that I just wanted to highlight and was asked to highlight is some of the needs of the building itself. The building itself is over 50 years old. Much of our equipment is about that same vintage. And so when we worked with the county facilities staff to take a look at our building as a whole, we have a myriad of possibilities that could and should be done for the building. It exceeds a $5 million price tag, and that's kind of what started, or at least enhanced, the need to look at the future of Samaritan. So this is a little bit of the laundry list, and we'll hear a little bit more later from Whiffley. That's what I have to present, and I think we can turn it over to Whiffley unless people have questions for me, or we can wait.
Well, what's your pleasure? Wait for questions, or does anyone have any questions right now at this point? Nope, looks pretty good. And Whiffley is the consulting firm that the county hired to present us with their report on after examining Samaritan and the future of nursing homes. So we'll give the floor to them.
Sure, thank you very much. I am Patrick Carroll. I'm a manager in Whiffley's senior living consulting practice. Also with me today is Larry, if you want to go ahead and introduce yourself.
Can you hear me now?
Gotcha.
I was muted, I guess. I'm a principal at Whiffley, and I oversee our senior living services group, and obviously work with Patrick on this project.
So, and first off, I want to apologize for not being able to be there with you in person tonight. Both my wife and I have been under the weather the past few days, and she did have a COVID test, which thankfully came back negative a little earlier today. But either way, we thought that it wouldn't be appropriate for me to be there in person, knowing that I had a bug going on. So I apologize for that, and appreciate your understanding. Getting into the presentation. So we have been working on a number of items in this consulting engagement to analyze what should be considered for the future of the Samaritan campus. And if we flip over to the second slide, some of the items that have been done include a market study to determine the number of nursing home and assisted living beds that would be needed to meet the needs of the seniors in Washington County. Mary Beth talked about the facility assessment that was conducted to get an understanding of some of the investments that would need to be made to the current building if it were to continue to operate as is. Whippley also prepared a financial model of what we refer to as the status quo. And to develop that, we look at historic operations and trends in operations and project out the next 5 years of an income statement to gain an understanding of what are the financials going to look like, assuming there's no changes and things just continue to operate as is, the historic trends continue to operate as is, and give you guys an idea of the financial impact of not making any changes. And finally, we've been working on financial model scenario development, where we're starting to look at the impact of potentially doing a construction project and how would those financials shake out. So that financial model scenario is in good shape, but not ready to be shared tonight. So if we flip forward to slide 3, the purpose tonight is to provide a background on the work that's been conducted thus far and an update of kind of the status quo and the market study type work. So before I get into it, I'll pause for any questions.
We're good so far.
Okay, thank you. All right, moving on to slide 4 and then slide 5, get into the market demand assessment. And high-level overview of what we're doing when we conduct a market study or a market demand assessment is we are looking at demographics of the market area, which in your situation, we define that as Washington County. So we pull information such as population demographics for current day and then projecting forward 5 years. Income data, net worth information, housing value type information. So we look at demographics, then we look at the other providers in the market area, again, Washington County, and identify the number of beds that are operating in the area by type of option, skilled nursing, assisted living, dedicated memory care assisted living. And then finally, we look at utilization trends and kind of come up with a calculation that gives you the bottom line. What is the estimated number of beds that are needed by option to serve the residents of the county? And we look at that again, current day and then projecting forward 5 years. So starting with the nursing home, ultimately we found that there is an excess capacity of skilled nursing beds in the county. Current day approximately 75 beds, and that is projected to increase to approximately 120 beds by 2025. Part of what's driving that estimated increase in excess capacity is, although the senior populations are going to be growing over the next 5 years, there's also been a decrease in utilization rates for nursing home beds. So we apply that trend to the 5-year projection, and although there's population growth, the decrease in utilization of skilled nursing services has been significant enough where we're projecting there to be additional excess of beds in the next 5 years. So there's 4 other nursing homes in the county, and we did a survey of those providers to gather some data. From those surveys and other data that we looked at, we ascertained that at any given time, at least recently, there have been approximately 80 open beds in the county, which anecdotally ties well to the calculation that we did where we estimated there's an excess of 75 beds in the county. One provider, Cedar Communities, recently downsized their nursing home capacity, and they have the best occupancy trends. And then there's also Virginia Highlands and the Pavilion, which also have historically open beds. So moving on to slide 6, this is the summary of the actual demand calculation that we did. And we looked at it from 2 perspectives. One is defining a primary market area, which is where a majority of your residents have resided prior to taking residency at the nursing home. And based on admissions data that was provided, almost 60% of the residents in Samaritan Health Center originated from the 2 West Bend zip codes. So we did a calculation for just the primary market area, and then vast majority of the additional residents in the nursing home originated from the county as a whole, which again was that total market area that I talked about. So you can see that that bottom line titled estimated over under capacity in both scenarios is relatively consistent, where we're calculating the total number of beds in the area, applying our population data and utilization rates, and coming up with that estimation that in the total market area for the county, you're overbedded by approximately 75 beds current day, and that should increase over the next 5 years. Before I move off of that and get into the assisted living analysis, any questions on just the demand analysis for the skilled nursing?
Pam, you had a question?
Yes, I'm Pam Conrath, District 15 Supervisor. I do have a question regarding your data. You speak of it being 2020. Is this just a point in time or average to date for the fiscal year 2020? Or you do have a little statement underneath there based on management historical operational experience. So could you clarify or define that a little bit more for us, please?
Sure. So 2020, the projected demand line item, that's saying at any given time during the year, there should be, we'll just look at the total market area of the county. At any given time, there should be approximately 390 residents in a nursing home. And when we move that forward, the population demographics that we get from our demographic provider, which is a national firm who they actually do the projections of the population data out to 5 years. That again is in 2025 at any given day during the year. We know occupancy fluctuates, but at any given day, there should be approximately 350 residents in the nursing homes across the county. The first notation about the utilization data, that's where we're looking at actual use rates within areas of the state and applying that to the population data. And we're also looking at utilization trends, historic trends, and that's where we come up with the assumption that over the 5-year period, utilization is going to continue to decline. The comment about based on management's historical operational experience, that really applies to the analysis for the primary market area or the 2 West Bend zip codes. So we looked at, I think it was a 3 or 4 year period of actual admissions data that was provided by management. And each resident, we looked at what zip code did they reside in prior to coming to the nursing home. And so that helps us understand where you're generating your residents from. So based on that data, almost 60% of the residents in the nursing home historically have come from the 2 West Bend zip codes. In the county, I use 100% because once we add it up, it's not quite 100%. You are getting some residents from outside of the county, but it essentially is 100%. And the focus is being able to serve the residents of Washington County. So we wanted to limit the analysis to what's the need for just the county. Does that make sense?
Lois, you had a question?
Hi, I'm Lois Krieger-Gundrum. I'm with District 16 in the Slinger area. So we have a number of CBRFs in Slinger. Recently, you know, in the last 5 years, there's been quite a growth. So how does that change with the number of new CBRFs and maybe other nursing facilities? I mean, how does that change with the population and what the needs are at the Samaritan? And I'm wondering, I'm just going to ask you, did you make a comparison to trends from 2015 to 2020?
As far as the utilization data?
Yes.
Yes, we did. I don't believe we applied the change from 15 to 20 because it was so steep. We settled on a change over a 3-year period. But yes, we look all the way back to 2010 to look at utilization trends. To your question, I guess 2 sides to your questions about the CBRF. The growth of the number of CBRF options in the state and in your area, that's one of the factors contributing to the decrease of utilization and for nursing homes. And we expect there to be continued growth in the assisted living space, which is why we assume that utilization rate for nursing homes will continue to decline. And that's why we apply a decreased utilization rate to the 2025 nursing home demand assessment. Looking at demand for assisted living, that'll be the next section that we'll talk about.
This is just nursing care. Is that what we're looking at here?
Correct. But to your question, you know, the growth of CBRFs is factored in here through the application of a decreased utilization rate, because that's one of the reasons that utilization of nursing homes is declining.
Okay, thank you.
Any other questions?
I don't believe so.
Okay. All right. Moving forward to slide 7. So this is where we're getting into our, assessment of demand for assisted living facilities. Specifically, we start with looking at what we refer to as frail elderly CBRF. And when we look at assisted living demand analysis, we focus on an analysis for individuals that would be able to afford to pay privately or pay for services directly out of pocket. And the high-level finding on that is currently there are enough CBRF beds or units in the county to meet demand for individuals that would be in need of assisted living services and able to pay for those services out of pocket. When we do the actual assessment, we take into consideration that the average age of an assisted living resident is over 85. I believe the latest stat nationally was, I think it was 84 actually for assisted living and 86 for memory care. So therefore, the projection assumes that a majority of demand would originate from individuals aged 85 and older. Also, from the income standpoint and the ability to pay out of pocket, we look at householders that are earning $35,000 or more annually, knowing that, again, on a national basis, the average income of individuals in assisted living is approximately $26,000 annually, which, if you look at the average rate, monthly rate at any assisted living facility, say it's about $5,000. Obviously, $35,000 a year would not cover that, but we know that when individuals move into an assisted living setting, they're relying on net worth and the sale of a household, sometimes support from their adult children to pay for those services. So we're comfortable with the $35,000 benchmark. When we look at specifically memory care services, so that's an assisted living that is offering dedicated programming to individuals with memory loss, Alzheimer's, and dementia. We know that the monthly cost for that is quite a bit higher than in just a standard assisted living setting. So we use an income base of $50,000. So again, that's a household earning $50,000 or more annually. There are a number of CBRF beds in the county, almost 800. Of that total, just half of those beds are dedicated to providing memory care services. So when we do the demand assessment, we look at demand for just frail elderly assisted living, which again, we think that the number of units and the population that needs those services is about right sized. There's not really too many, but there's not really a foreseeable need for more. However, there is a need potentially for additional memory care CBRF beds. And that's just kind of a supplemental finding that we do that specific analysis utilizing incident rates of dementia and Alzheimer's. Moving forward to slide 8, there is going to be a need for the services that the current CBRF is offering. So currently your CBRF is providing services to residents that are relying on a Medicaid waiver program called family care. And looking forward, that need is not going to be met and is going to continue to increase. So although there's not a need for additional CBRF beds for individuals that would be able to pay privately out of pocket, there will be a significant need for CBRF assisted living services for individuals that are going to need to rely on Medicaid dollars. Many private CBRFs either do not accept family care, which again is the Medicaid waiver program, or they limit the number of beds available to residents that are on the family care program. And the reason for that is the reimbursement amount that's received from family care doesn't cover the cost of care and operations. So your CBRF is meeting that need currently, and that need will continue to be there going forward. Moving forward to slide 9, looking at the RCAC, similar findings where the capacity is being met for private pay residents. The occupancy is throughout the county is relatively high, above 90%, which again suggests that it's right sized, but there's not going to be a need for additional RCAC beds in the foreseeable future. But there is a need again for your current operations. And your RCAC has historically maintained high occupancy levels. And with it being a newer product, it's attracted a higher or more favorable payer mix, with private pay residents historically being almost 60% of the number of residents in your facility, compared to 25% in your CBRF, where a majority of those residents, again, in the CBRF are on the family care program. Moving forward to slide 10, and actually maybe before I get into this slide, I'll pause for any questions on the assisted living demand assessment.
Pam?
Pam Conrath again, so District 15, Town of Polk, cover part of Town of Jackson. I am a nurse, and I do data. I do quality improvement data, deep dives and everything. And so I'm looking for some more information of where you came up with these projections and these statements that you have.
Sure. So when we're on the frail elderly assisted living side, we are setting a population age benchmark and an income benchmark. So we're first, again, starting with the demographics. So we're looking at, although the assumption is the majority of the residents will be aged 80 and older, we set that floor at population aged 75 and older. So anybody that's not aged 75 or is aged 74 or younger is not included in the demand analysis. Then we are looking at the income benchmark of households earning $35,000 or more annually. So again, if you're earning less than that, you're excluded from the demand calculation. Finally, we are estimating the number of residents that would need assisted living services by looking at nursing home utilization rates, applying that to the remaining income and age eligible population. We're applying incidence rates of Alzheimer's and dementia and removing that population. And then we're applying an estimate of individuals that would be independent and not in need of any health services, and removing them from the population. So we arrive at what we call a target population that meets those qualifications of being estimated to potentially need assisted living services. We apply that to the number of units in the market area. We account for any identified planned assisted living projects in the market area. And then we have three benchmarks that we look at. One is gross market penetration. The other is net market penetration. And the final one is project penetration. And so we have benchmarks for each of those. Gross market penetration looks at how much that target population that we calculated needs to be captured compared to the number of other units in the market area. Net market penetration indicates the ability to fill units as they turn over. So we use a national rate of turnover in an assisted living setting and apply that. And then finally, project penetration is what % of the population needs to be captured just to fill your units. And those benchmarks in order are 20%, 10%, and 5%. And if you're over those benchmarks, it suggests that the market is saturated. If you're under, it suggests the market can support additional units. And if you're right at those benchmarks, it suggests it's approximately right-sized, where you have the right amount of units for the number of individuals estimated to be in need of assisted living services. That's kind of a lot to go through without having that right in front of you, I understand, but is that helpful? Does that make sense?
Yeah, so to clarify, essentially you utilize a national benchmark tool.
Correct, yeah.
Is there a name to this?
Well,
National benchmark?
it's a combination of a number of data sources. So the nursing home utilization rates are specific to Wisconsin. The Alzheimer's incident rates are from a study from a university that breaks it down by age, and for some reason the name of that university is escaping me right now, but that's based on a study specific to Alzheimer's. The turnover rate is from a national publication called it's the State of Senior Housing Report. And then the actual benchmarks, those are kind of industry accepted benchmarks, where you're not going to necessarily find a specific report on that. Each consultant kind of takes their own approach, but in general, those benchmarks are industry accepted benchmarks, referring to the gross, the net, and the project penetration rates.
All right, thank you.
Any other questions? I have one. I'm going to go back to slide 8, the last bullet point. You were talking about whether the state will continue to fund the family care program and other Medicaid waiver programs. What's the feeling on this? I mean, I don't know if there isn't one out there or not, but I guess that would impact a lot of this if there's a trend.
Well,
or
I'll give my quick thoughts, and then I might turn it over to Larry to jump in as well. We don't have any indication that they're talking about not continuing the family care program or Medicaid waiver program. But with any of these programs, you never know what's going to happen over the upcoming years. So although we don't have any indication that there's going to be any changes with, the changes in reimbursement in the nursing home facility that we've seen over the years, and efforts to try to decrease the cost of care to the government, you just never know what is going to happen. So it's just something that we want you to be aware of. Larry, I don't know if you have anything to add on that.
Yeah, I mean, first of all, remember that in between the state and the provider in family care, there's the MCO, the Managed Care Organization, and many of them have struggled financially. So again, if we think about the future, we have a larger population that's going to need services, right? And the biggest change with family care when it came in was it eliminated the waiting list, right? Remember, we used to have the slots where every county had so many slots, and you could take care of people based on how many slots of care you had, in essence. When family care came in, it eliminated that waiting list and pretty much provided this service for everybody. Well, if we think about the need going forward, and again, you hear all kinds of stories about how prepared for retirement, the upcoming baby boomers are, most of those statements, I would say, are negative about how prepared they are. And so again, it's going to come down to, are we willing to fund care for everybody through the state budget? That's really what it's going to come down to, because the way to limit the cost of the state would be go back and say, we're going to limit it. We're going to put that limit on like we used to have, and you're going to have to be on a waiting list in order to, get services potentially. So I think the risk to me is the increased demand and the challenge that's going to put on the state budget, and how the legislators decide to deal with that. So.
Okay, thank you.
Any other questions?
Nope, guess not.
All right. So getting back to slide 10, this is just kind of a summary of considerations based solely on the demand analysis. And as we talked about, you can see that based on our calculation, the number of current nursing home beds are not needed, and you could downsize the nursing home and still meet the needs of the residents today and just looking out 5 years. The CBRF and the population that is currently being served is, there's going to be a need for affordable and low-income assisted living units. So just not from a financial, but just a demand perspective, those units are needed. Same thing with the RCAC. One consideration, which we'll get into this in a little more detail in the next set of slides, but there's going to be staffing shortages. Not only today, everybody's dealing with it today, but it's going to get much worse in the future, which would be another consideration when you're talking about potentially downsizing the nursing home. So moving forward to slide 11 and then 12, these next couple sections are really some of the background data that drove those demand findings that we just went through. And I won't spend a ton of time on this section unless anybody has specific questions, but we have a summary of the nursing home providers in the county. You can see on the bottom table the historic occupancy levels, which again supports that there's probably too many nursing home beds for the county. Flipping forward to slide 13. This is, again, just some background information on other providers in the county and then also some providers in surrounding counties, just to give you a little more background. But we summarize 5-star ratings, the number of private rooms available. Mary Beth hit on the importance of having private rooms available, and then the actual rates that are being charged. And you can see that Samaritan's right about in the middle as far as the private pay rates that are being charged. Flipping forward to slide 14. This is some, again, historical data that shows the average daily census and kind of the payer mix. And some facilities are performing well as far as a payer mix and attracting Medicare and private pay residents. And some facilities are very heavy in the serving the Medicaid population, which is the current case for Samaritan. Flipping forward to slide 15. This is a summary of the CBRF providers in the county. And based on our surveys, there's high occupancy, 95% occupancy on average is very good. It's essentially running full. And then finally, slide 16 is a summary of the RCAC assisted living facilities in the area. Again, surveys suggested high occupancy rates. So that's really about it there. Any questions?
No, I guess we're
Okay.
good there.
Okay. Next set of slides, moving forward to 17 and then 18. This is the demographic data that also went into the demand calculations. And just to kind of set the stage, this is kind of a national focus type slide, but I'm sure everybody's heard about the coming baby boomers and the aging population. In reality, we talked about the average age in assisted living being approximately 85. The first baby boomer turned 75 in 2021. And so there's kind of 5-10 years until baby boomers at the front end are really hitting the senior living industry, the assisted living and skilled nursing homes. So when we're looking at those 5-year projections, 2020 to 2025, we're still not seeing a significant impact from that baby boom population. And you can see that the number of individuals aging 75 and older each year for the next 10 to 20 years is very significant. And when we get to 2030, when those baby boomers are becoming approximately age 85, that's when there's going to be significant stress on the senior living industry. And that's when the need for assisted living and skilled nursing units is really, I talked about that population growth was not keeping up with a decrease in utilization for nursing homes. That's where you're going to see it flip, and that population growth is going to outpace that decrease in utilization. Flipping forward to slide 19. This is the population data specific to Washington County for current day and then 2025. And really what I have highlighted there is over the next 5-year period, you can see the increase in individuals aged 75 and older versus the increase in individuals aged 85 and older. So over the next 5-year period, 75 and older is going to increase 25%. 85s and older is only going to increase 5%. But then you look at the next 5 to 10 year period after that, well, that bucket in the 75 plus group is going to start moving up to the 85 plus group. Moving to slide 20 and getting back into the issues that we're going to have with staffing. We do a calculation that we refer to as the worker ratio. And that calculation is persons aged 20 to 64. So majority of the people that you would find in the working population compared to individuals aged 65 and older and 85 and older. And again, with the increasing aging population, over the period of 2020 to 2030, the worker ratio for individuals aged 85 and older is projected to decrease 30%. So I'm sure you're aware from discussions with Mary Beth that there's already issues attracting staff for senior living providers. And that's just going to get worse in not only the near term, but the long term. Flipping forward to 21, this is the household income data that I referred to as a contributor to the assisted living demand assessment. And you can see that for individuals age 75 and older earning $35,000 or more annually and $50,000 or more annually over the 5-year period, there's significant growth in those groups. So 35,000, approximately a 34% increase over the next 5 years, and 50,000, almost a 50% projected increase over the next 5 years. So that's it on the demographic data that's kind of relevant to our discussion today. Any questions on that?
No, I think we're good to go.
Okay. All right. So the next section is the facility assessment that Mary Beth referred to. And, you know, what we have here, obviously Whippley did not prepare this. It was prepared by Washington County Facilities Management in April 2019. It's relevant to this discussion because there's a financial impact to continuing to operate status quo. So we wanted to include these slides that have specific line items of what needs to be addressed and the timing that they need to be addressed. So over the next 6 months to a year, they're identifying about 1.1 million in items and costs that need to be addressed. Looking forward to about 24 months, an additional 2.2 million. And then the next 3 to 5 years, about 1.5 million. So ultimately, there's about $5 million of renovations and upgrades that will need to be addressed if you continue to operate in the current facility. And right now, maybe I'd turn it back to Mary Beth to see if she'd like to add any additional comments to this.
Thanks, Patrick. And I can certainly entertain any questions that somebody might have. We have tried to be really prudent with what the needs are and balancing that. We've, as I've referred to in several other presentations, we've rented a chiller. So we do have the services of the air conditioning within the building. We pay about $11,000 a month for that for about a 4-month period of time. We have looked at some scenario planning of what happens if some of these other things go down, and what's some of our backup plans. But at this point, to invest $380,000 in new windows for the dining rooms up on 5th floor, where the need is there. They're not falling out. We're kind of making do. So Band-Aids, yeah. And quite honestly, the facilities crews have been great in looking at, what can work. So.
Yeah. Okay. All right, Patrick.
Okay. I'd like to point out something very minor that I just noticed. I see that when we finish up the demographic projections on slide 21 and get into the facility assessment, we jump to slide 32. You're not missing a chunk of the presentation. I'm not sure what caused that, but I apologize for that, but wanted to point out that you're not missing 10 slides of presentation here. So moving forward to the status quo financial model, which is slide 37. Again, what we are trying to accomplish with this status quo financial model is to assess the financial performance of not making any changes whatsoever and having trends continue over the next 5 years. And kind of the high level findings is, there's some pros and cons to maintaining the status quo. Financial performance is projected to deteriorate. You have that kind of $5 million hanging out there, and as the facility improvements aren't addressed, that can impact the quality of resident life. But there's no additional debt for the county, which is obviously a significant factor. But you may decide that based on the model that we build out, it might not be viable to remain in the senior living business. So kind of getting into that actual model and the data that we looked at, moving forward to slide 38. I'm not going to spend a ton of time getting into this detail, but can certainly field any questions that you may have. But again, the projections based on historic trends. So we're assuming the nursing home payer mix with approximately 70% of your residents being Medicaid and family care is going to continue for the next 5 years. And same for the remainder of the payers. Smaller Medicare population and a smaller private pay population. The rates that we use are based on historical rate increases for some of the payers, and then your private pay rate increases. And one other item is the model does not include any county tax levy funds. Moving forward to 39, one item that we want to make sure we're upfront about and is understood, there is governmental nursing homes receive payments from a supplemental payment program. And over the past couple years, this is from the state, there's been excess funds in that program, which have been paid out to the providers. And last year, Samaritan received an additional payment of $700,000. In our projection, we have assumed that there will not be a surplus going forward, and the payment will be strictly in accordance with the award letter that you received and that management provided to us. So in prior year, there's approximately $700,000 of funds that we're not assuming over the 5-year period. And a couple reasons. If we look back over a 5-year trend, 3 of the years there was no additional payment, and 2 years there was. So we don't want to count on that. Also, we know that in our current environment, there's going to be significant stress on the state budget. But we want to be upfront and point that out, that is not, those excess payments are not included in the financial model. Before I move off, does anybody have any questions about that?
Well, we're good.
Okay. Moving forward to slide 40. These are some of the assumptions on the expense side. Historic wage increases at Samaritan have been 4%. That's what we had built into the model. Health and dental benefits based on historic trends. Routine expenses, just a standard inflation of 2%. Likewise with utilities, bad debt has been based on historic operations. The depreciation expense was a calculation provided. And one other item that we want to point out is on the expense side, there's the WRS pension expense, which is WRS is the Wisconsin retirement system. And that expense is booked based on a number that's provided by the state. So there's no actual cash that Samaritan is putting out for that expense. And it's really based on the performance of the state's pension fund. And in 1 year, they can do their analysis and determine that that fund is underfunded and add an expense to the books. In other years, they could determine that it's overfunded and there'd actually be a credit to expense. So since it's a non-cash item, Samaritan has nothing to do with what that number is. To normalize the numbers, we excluded that expense from the projections. Any questions on that?
No, I don't believe so.
Okay. So slide 41 is the actual statement of revenue and expenses that we show the actual results of 2019 and then forecast 2020 through 2025. You have your operating revenue, your operating expenses, your income or loss from operations. Below that, that's where we make that adjustment to remove the WRS expense and arrive at a line item that we just referred to as income or loss from true operations. So that bottom line is really the number that you want to look at. So you can see that going forward, the bottom line from operations is projected to deteriorate. And the big story on that is the increase in revenues is being outpaced by the increase in expenses, and it just compounds year over year. Below that, we try to show a little bit of a cash flow where we're adding back depreciation and non-cash expense, and same deal with provision for bad debts, but then show the current debt service payment to arrive at kind of a cash flow type number. Any questions here?
Nope.
Okay. So moving forward, next steps. Slide 43, we kind of talk about some considerations. So one consideration is to construct a new nursing home that's downsized, has less beds. Potentially construct a new CBRF. Another consideration is to continue to operate as is. And a third consideration is to exit the business. Moving forward to slide 44, some considerations that are specific to county nursing homes and CBRFs is that although there's really a trend to serving higher acuity type residents in a CBRF or assisted living type setting, and the little less reliance on the nursing home, when you're in the county home, you have that supplemental payment program for Medicaid residents. So the reduction in cost for providing care in the nursing home setting versus a lower cost in the assisted living setting is really not offset, because the reimbursement that you receive for that Medicaid resident in the nursing home due to the supplemental payment program is going to be higher than what you're going to be receiving from family care. So that's why it's not always a no-brainer to kind of build a larger assisted living and a much smaller nursing home. Also, there's what's kind of referred to as a heightened scrutiny process, where in order to qualify to receive reimbursement from family care on the assisted living side, there's kind of a tenuous process that you need to go through with the state to get their approval to be able to receive the family care payments. Larry, do you want to expand on that?
Sure. So the basis of heightened scrutiny is really to move people out of institutional-like facilities. And so Patrick mentioned the heightened scrutiny, and because you're a governmental facility, if you have a CBRF or you open a new CBRF, you have to prove that that CBRF isn't institutional, that it's more resident-based. And most CBRFs are built that way, but the hard part is getting through the process, because it's still a pretty new process, both at the state and federal level. So, but in order to accept family care, you have to be deemed and have received a waiver to show that you are, you meet that heightened scrutiny, that you aren't an institutional type provider.
So Mary Beth, can we get through this process?
Yes.
Okay, thank you.
All right. So I think here the final slide that we have is the next steps. So we talked about preparing a financial model to look at another scenario. And so what we're currently working on is a financial model to assess the viability of constructing a new 50-bed nursing home and a new 30-bed assisted living. And I guess there's a specific reason we're looking at 50 beds versus 60 beds, is looking back again on Medicaid reimbursement. The state has an incentive program, they call it a small bed incentive program, where they provide additional reimbursement for nursing home facilities that are 50 beds or smaller. So if you were to construct a 51-bed nursing home, then an extra incentive payment goes away. So just to kind of give the rationale behind looking at 50-bed. On top of that, when we look at the market demand analysis, that's an 81, that's downsizing of 81 beds. And the analysis suggests that that's approximately how much the county is overbedded currently. So we're building out that financial model, and we'll be sharing those results with Matt and the various committees going forward. My understanding is that there's a task force being formed and we're going to be participating in discussions with that group. And another item that we spoke with Matt and Josh about is looking at obtaining a high-level preliminary architectural report so that you have an understanding of how much this construction project would cost. We have a range of numbers that we can play with based on our experience, but it's best to get a number directly from the architect and not be surprised once you get kind of too far down in the process. And that is about all we had prepared for discussion today. Happy to take any other questions that you may have.
Anyone have questions at this point? Pam?
Thank you. Pam Conrath again. Your last next steps here did, and the rationale behind the requesting for a 50-bed nursing home made sense. It seems like a happy medium. I would just like to make a statement that when I did go around door to door this past year, inquiring my constituents, their thoughts on a nursing home, I did, share with them that was, main reason why I was tapped on the shoulder to run with being a nurse, and that was lacking on the board. But, we are very conservative, but the consensus still was supporting maintaining the services for a county-run nursing home, even to the point where I shared with them it might mean a referendum and increased taxes. And truly, there was not one person who said that they would not support that when I went door to door. So I just wanted to share that statement with you all. But also, though, with being a data person that I am, I know there's a task force and things being developed. I would like a little more details with these projections. I've been in acute care myself. My whole career, most of it critical care, and hospitals probably year to year run about 70 to 80% capacity. But that's due to, summer months typically we're lower. We can be like at 50%. We close units, we close ICUs. And then during the fall, the flu season, we're overflowing. We used to divert years ago, but yet we would still add beds. So just that raw number at the end of the year doesn't, quite tell the whole picture. And I remember too being on the other side in acute care where we couldn't move people out of the hospital because there weren't rooms for them. So they had to stay in the hospital and wait for that assisted living or nursing home or CBRF to open up because everyone was full. And that does, vary, that ebbs and flows different times of the year. So just, looking at a raw annual number, I would like to see some more details, like a month-to-month type of graph. Thank you.
Did you want to say something about that, Josh, or? Okay. Just to address Pam's comment, we certainly have an obligation to listen to our constituents, but we also have an obligation to look at all the information that's provided to us as a supervisor and take that into consideration too, because what we're doing is what we feel is the best thing for everyone in the county, which is what I hope all the supervisors do. Are there any other questions from any of the members here? Then County Exec Showman, if you have comments, please.
I'm going to try to speak loud enough so I'm hitting that microphone so that they can hear it out in TV land. But I just wanted to say a couple of things about the next steps of the process and what I envision. And thank you, Supervisor Conrath, for your comments. They're very helpful. Mary Beth and Matt, I'll be sure to be talking to them about how exactly we can get you the detail that you're looking for, so you're comfortable when you make a decision, because that'll be impactful on the rest of the county board ultimately when they're asked to make a decision. Same for all of you. If you're interested in additional detail, please talk with these two or get a hold of me, and we'll make sure you get answers to every question you have. That being said, we're working right now. Matt and I just got done putting together a timeline for what we expect with the task force. We hope to have that out and up and running here in the next few weeks, starting in the month of August. I don't expect this to be a terribly long process with that group, but I did promise while I was campaigning over the last several months that we would have a task force, and we'd really look for community input, focusing on the people and asking what really they wanted to hear. So it's very helpful to hear door to door what people are saying, but I think it'll also be helpful to hear from our constituents in the form of a task force as well. What ultimately we would like to see from them is about a 2 to 3 month process, starting sometime in the month of August. We're generically thinking, a couple of hours per meeting, maybe 2 meetings per month on average for 2 to 3 months. And of course, the committee can do whatever they want, but just to kind of give you a flavor for what our thoughts are for how their meetings might work. They'll get a number of things. They'll get a very similar presentation to the one that you just saw, give them the background and a little bit of the homework to actually get the creative juices flowing. We also plan to bring in some industry experts for them, both from the area as well as kind of from the state or much more macro level. So they're able to kind of think through all the different components of it. And then ultimately, we've got our individual local experts that can help as well. So we're going to try to give them a flavor of how everything operates. At the end of the day, I talked a lot on the campaign trail about the possibility of going to referendum. This may be something that ultimately we have to ask the experts. As you heard in the presentation, the proposal that we're seeing today is quite a bit different from what I talked about on the campaign trail, which is good in many ways. Likely, if we go down the path of this smaller, more manageable facility, you're probably talking about less government, less employees, something more manageable, and probably less cost. What that likely means is the chances of needing to go to a referendum go down. The lower that cost gets, the less of a need for us to actually have to go on a ballot. And so right now, with what Whipley came back with, I'm really thinking this is a decision that the county board probably has the capacity to make if you feel inclined to make that. Based on what they're recommending with the smaller facility, it would be my recommendation that you do that. It also is helpful to understand that really what you'd be asked to fund is really the debt obligation of the new building. Whereas before we were thinking it was going to be maybe the debt obligation and some operational expenditure. Now it's really, if you're going to build a building, if you decide that that's the right thing, if the task force thinks that's the right thing, in that case, then can we afford it? And of course, for those of you well, the three of you are familiar with county government, but for your sake, Supervisor Conrath, we can borrow money. The county board has the authority by state law to borrow money without going to the constituents and asking. That's different than school districts, for example. But you need a 3/4 vote of the county board supervisors. We think we certainly have the debt capacity to do that. I also think, based on the little bit I know from what Whipley's telling me and how our finances work, we can do all of that and still reduce the tax rate. Probably in 2022, we're a little bit late in the game for 2021, but I think you still have the ability to reduce taxes and do this. Now, that means you won't reduce them as much as you could have, at least reduce the tax rate as much as you could have, and you are going to increase government spending. So those are the things that you kind of have to weigh as a public policy decision. But that's certainly how we're going to present it to the task force. So at the end of the process, I'm thinking we come back to your committee, the task force, with a recommendation. Hopefully the chair of that task force, whoever that person is, will come to you and explain what they heard and saw and what they feel. and then make a recommendation to you. Obviously, then your job is to take that information. I'm sure probably get more from this group, from Whitfleet, from whoever you feel you need it from. And then ultimately, what I'd like to see is the county board is making a decision very early in 2021. So January or February, somewhere in that ballpark, certainly in the first quarter of 2021. If we're able to accomplish all of that, if we're exiting the business of long-term care, there will be a timeline that goes with that can be talked about at that time, but that'll be certainly 12 to 18 months of unwinding decades and decades of work. On the other hand, if you decide that you're going to go into a building project, you're probably talking 12 to 18 months of what that looks like, including what happens to the 1960s building. So I have some guarantees that Mr. Furno will stick around and help us through that, and Mary Beth will stick around and help us through that in either event. So I feel comfortable with either way moving forward, but just know either one of those decisions, you're really looking at the majority of 2021, probably a good chunk of 2022, which means your debt payments for the treasurer in the room, really, you're probably not going to see them until 2022. I would anticipate the first quarter of 2022 for principal payments and interest payments in October or vice versa, depending on how we structure the debt, if we were to do that. Conversely, if there's some other idea that we're able to come up with over the course of the next 3 or 4 months, that could turn everything on its head too. There's certainly plenty of options that we could consider as alternatives too. But I feel very good about having this narrowed down. You'll notice even in the presentation, there was 4 options kind of when we started. We really narrowed it down basically to 2. And of course we can diverge from those 2, but it seems like a much simpler question than we originally thought. And I think that's a good thing. So I'm available also if you have any questions. Otherwise, that's what I have. Please.
When you and I talked earlier, you said that currently it's kind of a break-even operation. Okay, and you said that in what you had just talked about now, you said there would be additional spending, and I'm assuming you're talking about the debt payment. And that it would still maintain a break-even, but the only additional spending you're talking about is the debt. Principal and
Yeah, that's correct. That's my feeling is, and based on the conversations both with Whitfleet and with Matt and Mary Beth, the debt, if we can cover the debt, they can handle the operation.
just one more thing, so you're looking at a $5 million investment in this building. Okay. Would you, so I'm sure these are things for the task force to go over, but to determine whether or not you can modify that building into the 50-30 mix that you're also looking at. I'm assuming that's going to be one of the things you're going to be looking at.
Yeah, actually, we feel like we're not going to look at it. The expenditure of that was originally, like, and you saw it in the first part of the presentation, that was originally part of the thought. The more that we looked into it, the more you kind of go, this building it's basically a tear it down to get out of the business or a tear it down to do something else option. So I don't see any scenario where we're remodeling that facility at this point. If you've never really kind of walked through it, it's basically a concrete bunker. It was built in the 60s very well. You can't do much with it. Fiber optics through the walls and things like that. Yeah.
The task force, would those be open meetings so that if supervisors, if they aren't on the task force, they could come and listen?
Yeah, that's correct. We'll have them publicized like a normal committee meeting. Yes. And if you'd like, we can copy this committee on all of them. You know, normally we don't do that for everyone else, but we could do that if that would be helpful.
We would appreciate that. Yeah.
One more question here, just something for the task force to consider. We're looking at this projected, 50-bed type unit. Okay, now what if that ends up not meeting our needs? We build this, new facility and, oops, you know what? The county needs aren't being met. It looks like we need more beds. So I would just like the task force to consider that plan when they're strategizing, please.
Absolutely. Yeah, we can absolutely do that. And one of the things I don't know how much detail they covered in the presentation I was reading on and off, but the adaptability of the concept that they've built with the CBRF and the skilled nursing facility will accommodate for some of that, and we can go into much more detail in that. Of course, building on it would always be an option, but the flexibility and really that was a concept of the Whipfly team in collaboration with Matt and Mary Beth, being able to transition those beds back and forth. I'm concerned about capacity. I'm more concerned about what the hell is going to happen to Medicaid and Medicare. Yeah, well, yes. Trust me, you ask the guys from Whipfly, I badgered them pretty brutally on that question.
All right, any other questions from the members? Okay, I guess that's it then. Thank you. Our next meeting date is Wednesday, August 26th, and there being no further business before the committee, we stand adjourned. Thank you, everyone.
Thank you.